think what's happening with the heart failure is that there's a lot of interest now in patients with normal ejection fraction and heart failure, as you know, PFF. And this is actually what we have in the guidelines now. For example, I think has been taught earlier by Dr. Alagason, that you have to look for 4 criteria here: average E to A prime ratio more than 14, septal E wave velocity less than 7 centimeters, lateral E prime velocity less than 10 centimeters per second, TR velocity more than 2.8 meters per second, and LA volume index greater than 34 mil per meter square. So if you have less than 50% positive, it's a normal diastolic function. So the patient will not have any diastolic heart failure. And of course, if more than 50% are positive, these people will have diastolic dysfunction, maybe increased LV filling pressure, and therefore they will go on to have diastolic heart failure. But then there is a large group of patients where they only 50% are positive, and that's indeterminate. So even with this classification here, many of the patients cannot be classified as having normal diastolic function or diastolic dysfunction. And actually, if you look at this diastolic diagnosis of heart failure with preserved ejection fraction, HFpEF, is challenging in patients with E-volemic patients with dyspnea. So Dr. Yogesh Reddy from Mayo Clinic, and this was published actually in 2018, he took 100 patients with unexplained dyspnea and studied them by cardiac catheterization. So it's just not like guidelines. This is a real study. And what he found, of these, age 61 patients were diagnosed with HFpEF by increased wedge pressure of 15 millimeters or more at rest, or more than 25 millimeters of mercury during exercise. And 39 patients without these findings served as actually controls with non-cardiac dyspnea. So this is the group he studied. And what he found was, he developed this criteria, what they call H2 FPEF. He only took, in these patients, only actually 2 were actually criteria, echo criteria were found to be useful. One was Doppler echocardiographic index, mitral E to E prime, greater than 9. So he gave it as 1 point. And the other one was, if you look number 4 on the top here, that was actually pulmonary hypertension, where the Doppler echocardiographic estimated pulmonary artery pressure was greater than 35 millimeters of mercury, again 1 point. But the most important findings they found were actually non-echo, and that was patients were heavy, the body mass index was greater than 30 kilograms per meter square, they were hypertensive on 2 or more antihypertensive medicines, and many of them also had atrial fibrillation. So out of this criteria, if the total sum, you can see the points are given, maximum points are given to atrial fibrillation, very few points are given to echo, and if the maximum was around 0.9 or so, some of them 9 or so, then there were about 90% of chances that these patients had heart failure with preserved ejection fraction. So out of these 4 or 5 criteria, only 2 actually were found to be useful on the echocardiogram. And there was an editorial after this paper which says, at last we have a properly validated diagnostic algorithm for heart failure with preserved ejection fraction. But on the other hand, some people criticize this study also because it did not actually look at the clinical phenotypes which predispose to heart failure with ejection fraction, and also the specific plasma biomarker profile were not actually taken into account. So that was one problem with this study here. And then, so what he thought was that this H2 score of 9 or more should be used for unexplained dyspnea in the absence of other causes of heart failure. So if you have to rule out the other causes of heart failure, and then you can actually use this score to diagnose heart failure with preserved ejection fraction. As you know, it's challenging to do that. You do not always see the jugular venous pressure very easily in patients, in some of these patients. Then the European Society of Heart Failure, that's the Heart Failure Association of the European Society of Cardiology, came with their guidelines how to diagnose heart failure with preserved ejection fraction. So they had a consensus recommendation. Now these are not validated in a way, completely validated, but they are actually recommendations which they thought. And what they do, actually they made it, it's quite complicated here, but what they looked at 4 criteria: functional, morphological, biomarker, and also biomarker in sinus rhythm and biomarkers in atrial fibrillation. So they looked in the functional one, were actually the echocardiographic criteria, was again the septal E prime velocity less than 7 centimeters, lateral velocity more than 10 centimeters, or average E to E prime more than 15, or they also looked at tricuspid regurgitation velocity more than 2.8, which means the PA pressure was greater than 35 milligram mercury, and they called it one of the major criteria. Another major criteria were morphological. This also echo. So here echo played a larger part on this in this particular guideline. So here the morphological criteria were LA, left atrial volume index, as we know, greater than 34 mil per meter square. So that is what they use for morphological. And biomarkers, as you can see, that were either anti-pro-BNP more than 220 picogram per mil, or BNP greater than 80 picogram per mil. And if there are atrial fibrillation, the criteria were higher, because as you know, atrial fibrillation itself can increase some of the biomarkers. So they went with anti-pro BNP greater than 660 picogram per mil, or BNP greater than 240. So this is a higher biomarkers in that one. And then there's some minor criteria. Now, interestingly, in the minor criteria, they use the GLS, the global longitudinal strain. If you look at the, if you look at this, let me show you with the pointer here. Don't think they use this one here. They went for either average E to prime ratio 9.14 or GLS less than 16%. So in this, they use quite a bit of echocardiographic, functional and morphological were all echocardiographic criteria, but they also combine it with biomarkers. And then in the minor one, where it had 1 point or so, they use the global longitudinal strain less than 16%. And of course, if these patients had 5 or more points, greater than 5 or more points, they thought that these patients will go for heart failure with preserved ejection fraction. And so this is how the criteria, they had their criteria here. So quite a few things have evolved since actually, since original studies that we looked at E to A ratio, et cetera, diastolic dysfunction. There's quite a bit of evolution here. And of course, this criteria is a little bit more complicated, because within each domain, a major criterion scored 2 points or a minor criterion 1 point. But each domain that I told about, 4 domains, can only contribute maximally 2 points. And so that was one of the problems. It becomes a little bit difficult to follow these criteria. But at least in this criteria, echo played a very large part in addition to the serum biomarkers. So here, for example, they said if you have a breathless patient, first of all, you go for clinical assessment compatible with heart failure ejection fraction, rule out other cardiac and non-cardiac causes. Then you, of course, will be doing the standard diagnostic tests like peptides, ECG, X-ray, echocardiography. And if the pre-test results were suggestive of heart failure preserved ejection fraction, then you go for these scores that you mentioned here. But if there was still a problem, you still could not make a diagnosis, then they suggested a very important parameter, and that was diastolic stress test. So in the diastolic stress test, you do the diastolic stress test, and if that point in time the ratio goes up or the PA pressure goes up, then you can actually confirm that the patient has heart failure with ejection fraction, with preserved ejection fraction. So here it is. So if you look at the stress CSICON, now this is important now to do, and I don't think all of us are doing it still very much, but something very important to do in these patients. If you are not sure, you do them stress. It's a mild stress. You don't want them stressed too much, because then you would not be E to A ratio. E to A will fuse, and so there'll be a problem. So here they looked for average E to E prime ratio of grade 15 or more, and TR velocity more than 3.4 meters per second. And if you had this, if you fulfill these 2 criterion, then these patients would obviously have heart failure preserved ejection fraction. Now, if of course you had a problem with this, then you have to go for cardiac catheterization, where you make the diagnosis when the wedge pressure is 15 millimeters or more, or with exercise 25 millimeters or more. And again, sometimes if you have gone to actually cardiac catheterization and you're not sure what's going on here, we have intermediate figures, then you can go back and do a stress echo test. So this is what they had recommended in this patient. Now again, other people here, the European Association of Cardiovascular Imaging, that was the Heart Failure Association in Europe. Now here is the European Association of Cardiovascular Imaging. They have come with another algorithm for LV filling pressure. So what they do here is, let me go back here. What they've done here, they've gone for mitral E to A ratio. They say if your mitral E to A ratio is 2 or more, then the patient has got elevated filling pressure. So just look at mitral E to A ratio, nothing else. And then if the mitral E to A ratio is 0.8 or less, then they have got normal filling pressure. And if you are in between mitral to E ratio is less than 0.8 and less than 2, the mitral E to A ratio, then you do additional criteria, which would be E to E prime ratio greater than 14, TR velocity more than 2.8 meters per second, or LA volume 34 cc per meter square. If 2 or 3 of these criteria are negative, they're normal filling pressure. If 2 or 3 of these criteria, TR velocity, E to A ratio 14, LA volume 34 or more, then if these are positive, then the elevated filling pressure. And if you are in between, then they said, now what do we do? Then now you go to LA reservoir strain. So then you do LA reservoir strain, and if the LA reservoir strain is actually less than 18%, they've got elevated filling pressure. If it's more than or equal to 18%, they've actually got normal filling pressure. So this is a little bit easier criteria to follow. The only problem is whether you can always diagnose patients with having E to A prime, a mitral E to A ratio greater than or equal to 2, whether all of them will have actually elevated filling pressure. There is some sort of a doubt regarding that. So that's where it has gone to. Easy. Look at only mitral E to A ratio. And then, but then if some things are not very good, then you really have to go to LA strain pattern, which Dr. Sengupta mentioned. Now, this is not new. I mean, as back 1993, we published together with some research in Brazil, like here, if the E to A ratio is very, very high, we saw that their prognosis was actually poor. This red line reflects their prognosis very poor as compared to those where the E to A ratio was actually less than 2. So that's not something we are now going back to where we started. So we have advanced quite a bit in echocardiography, but sometimes we go back and relook at what we did in the past, like I showed you right now on this particular slide here. So that's where we have. So actually, left atrial strain, as actually Dr. Shantanu Sengupta showed, has become very, very useful. He published something in one of the journals in the United States. It is better than LV strain in diagnosing and or predicting outcomes in LV diastolic dysfunction, early stages of heart failure. And so this is again becomes something very important now to use. So we are now not only looking at global left ventricular strain, longitudinal strain, but we are also looking at now LA strain in some of these patients. One other thing has come up is lung ultrasound. I think how many of you are using lung ultrasound here at all? Well, quite a few. So that's great. Yeah. So lung ultrasound here. And if you look at the lung ultrasound, I don't think I can play this here. Let's see. Let me go back a little bit here. I don't think that plays very well here. But lung ultrasound, again, you look for these B lines. Normally, you get nothing, but these A lines here, which are actually like arc-like lines, transverse. And then when you have water in the lung, anytime you have water in the lung, that water interface produces these vertical comet-like artifacts, B lines. And if you see that, you know that these patients are pulmonary edema. Obviously, patients who have heart failure preserved ejection fraction will have some amount of pulmonary edema, some amount of water in their lungs. And so these B lines will become very useful. Now, they have not been incorporated, and then you can actually do stress. For example, I don't know whether you can show this. I may go back and see if that will play. But anyhow, if you had seen this in movie, you would see that and at rest there are few B lines, but when you stress the patient, there are more B lines, which also shows you that when you have some of these patients with the pulmonary edema, they even exercise a little bit, the edema gets worse. And you can see that very much using these B lines. And when you follow these patients, as the water in the lungs, as the pulmonary edema decreases, the number of B lines will also decrease. So there is some now question whether in the new guidelines which should come in the future, whether lung ultrasound B lines should be used as an additional criterion for diagnosing heart failure. So this is the way it has come up. As you know, This is a very difficult subject, and many guidelines have come in this. But starting with the American Society of Echocardiography guidelines, which I showed in the beginning, with where a lot of patients may be indeterminate, will be labeled as indeterminate. Then you come up with what Dr. Yogesh Reddy mentioned, but there are only a couple of echocardiographic criteria there. And then later on, we have gone into the into the new guidelines, and the latest one really pays a lot of importance to mitral E to A ratio of 2 or more than 2. Thank you. I think my time is just up. I just heard the noise here. So thank you very much for it. And of course, we'll be talking about artificial intelligence tomorrow, and that again we'll be talking whether artificial intelligence may be used in diagnosing heart failure with preserved ejection fraction. Thank you very much for your attention. Thanks a lot.